Hi, I'm Sean Fix with Emergency Medical Consultants. We're a national training center for a number of organizations providing continuing education for healthcare providers, fire, EMS, and industry. This video series that you're about to look at is designed to help you prepare for a certification course. Remember that it's not designed to make you leave your required manual or not do your required pre-course exams prior to entering the course. It's also a great review just for clinical practice and relevance. Hi, in this section we'll look at standard pharmacology for ACLS. And what we call this is Pharmacology 1. These are the drugs that are for the fairly serious patients that you need to be able to open up and administer fairly rapidly to the patient. We don't have time to calculate or do math or look up with charts with most of these first drugs. So these are for drugs for that patient who is either in cardiac arrest or having a significant dysrhythmia. So the first one we'll look at is oxygen. No great revelation that people in cardiac arrest need some oxygen or people having a cardiac event. However, what we've learned over the past several years is they probably don't need as much as we used to think they did or even as much as we used to give them. And in some cases, they don't need any. So when we think about that, we say that if a patient has signs of hypoxia and they're having a cardiac or a stroke event, then they might need some small amounts of oxygen. If they're not having signs of hypoxia, and that is defined as an O2 saturation of 94% or less in the stroke patient, and maybe even as low as 90% or less in the cardiac patient, or if they don't have complaint of dyspnea, shortness of breath, or they don't have pulmonary congestion, crackles or rales from congestive heart failure, they probably don't need oxygen. We know that giving too much oxygen in cardiac arrest causes a couple of different problems. The oxygen portion causes cellular toxicity. That is, as we hyperoxygenate the patient, it causes the cardiac and the neurological cells not to do as well in post-resuscitation or post-management care. We know that if we increase the ventilation rate or volume, we increase the pressure within the chest, which decreases cardiac output, which means your CPR is not as effective. Hyperventilation, overventilating patients, causes cerebral vasoconstriction, which then decreases blood flow to the brain. Certainly not something I want to do when I'm trying to resuscitate somebody. So what do we know? We know that most patients who need oxygen, who are still alive, are going to get it by nasal cannula if they're not in significant distress. And the nasal cannula flow is generally 2 to 6 liters per minute, though we are seeing some newer devices called high-flow nasal cannulas, which may be utilized over the next several years. A mask will give a patient 50 to 60% oxygen, and a non-rebreather mask may give them 90+% oxygen. So depending on the order from the physician or depending on what the clinician feels is appropriate for that patient will dictate how much oxygen you're actually starting that patient at. If a patient is not breathing or not breathing effectively, we need to ventilate them with a positive pressure device or a bag valve mask attached to oxygen. Remember that the rate on that is going to be much slower than previous or even much slower than some of the more recent studies have shown that we've been doing. The rate should be 10 breaths per minute, which is about 1 breath every 6 seconds or every 5 to 6 seconds on the adult patient or any patient in cardiac arrest for that matter. So when we talk about actual medications and drugs that we're going to be pushing into the patient in cardiac arrest, the first and the most common drug that we use is epinephrine or adrenaline. Remember that epinephrine is used in all cardiac arrest rhythms, and the 3 main cardiac arrest rhythms would be ventricular fibrillation, which is the same as ventricular tachycardia without a pulse, asystole, or PEA, pulseless electrical activity. Epinephrine can be used as an infusion in a patient who has refractory, that is, not responding to other treatments, bradycardia or hypotension, or a combination thereof. Epinephrine, I said, is adrenaline, so it increases the heart rate, heart force, heart automaticity. But what it does most importantly actually is increases peripheral vascular resistance. That means it causes the vessels to squeeze down. Specifically, we're concerned about vessels in the arms and legs, so that we're keeping blood up in the core as we do our resuscitation and not shooting blood down to somebody's feet to try and resuscitate them. The downside to this is it's a very aggressive drug, and it increases the myocardial oxygen consumption or the workload of the heart in a patient who already has a pulse. So it's not a great drug to just push into somebody without diluting it very, very significantly. So dosing on this, it comes in a 1 milligram vial. 1 milligram is the dose for cardiac arrest, and we give that every 3 to 5 minutes. Now, what I always say is if we're doing CPR sequences in 2-minute cycles and then stopping to recheck our patient, at the end of each 2-minute cycle is when we should be evaluating what medication to give. So that would mean that if I gave an epinephrine, did a 2-minute cycle of CPR, and checked the patient and he was still in cardiac arrest, and went back and did another 2-minute cycle of CPR, I would now be at 4 minutes and eligible to give epinephrine at the end of my 4-minute cycle. So I like to say give epinephrine every 4 minutes just to make your sequence work a little bit better. In patients who have refractory bradycardia, refractory hypotension, we may be able to take an infusion of epinephrine, mix it into a bag, and drip it in slowly in order to administer this to the patient. One of the things that we have to remember is that giving a push of cardiac epinephrine to somebody IV to try and fix bradycardia or hypotension when they are not in cardiac arrest can be very dangerous unless that drug has been super diluted, which is why we say use it in an infusion, put it in a 250 bag, put it in a 500 bag, and your system will have some type of formulary for this. The second medication we'll talk about for speeding up the heart rate gently without being overly aggressive on the heart is atropine. So atropine is used for bradycardia, heart rates below 50, where the patient is symptomatic, meaning they're having a decreased consciousness from this, or hypotension, or having ventricular ectopic beats, or PVCs. So this drug works differently than epinephrine. This drug works by blocking the effects of acetylcholine, or blocking the vagal nerve intervention to the heart. So it slowly allows the heart rate to speed up by increasing the discharge of the sinus node, so that you would get more P waves. And in a healthy heart, when you get more P waves, you would get more QRS complexes with that. The dose on this is 0.5 milligrams, and that can be repeated up to about 3 milligrams, or the book dose is 0.4 milligrams per kilogram. We have to be cautious if we think about what I said this medication does. This medication increases the number of P waves that you get, which hopefully increases the number of QRSs. If the patient's in one of the heart blocks where there's more P waves than QRSs, and we give atropine to increase the P waves, we don't necessarily get more QRSs. So while over the years they've wavered back and forth on the way to manage this, the general concept is this. If you're going to use atropine to try and increase the heart rate in a heart block, you should not give the full 3 milligrams. You should try it several times, don't rely on it, and have a backup plan for that, whether it be another medication or whether it be a pacemaker. So again, depending on where you work, your policy might be try atropine, your policy might be skip the atropine and go right to an inotropic drip or a pacemaker. So just food for thought. That's changed a number of times over the past 15 years or so. Next medication we'll look about is our ventricular dysrhythmia medications. And the one that we're talking about first is Amiodarone or Cordarone. This is the recommended agent since 2000 for ventricular fibrillation or ventricular tachycardia. Knowing the way this medication works, by blocking alpha and beta, it does control heart rate, but it can also drop the blood pressure if given to a patient who is perfusing. It blocks sodium, potassium, and calcium channels. So it blocks rapid conduction and rapid contraction through the heart, and it slows down repolarization. So in the emergency setting, we say that we use this drug for significant ventricular dysrhythmias. Those of you that are in the cardiac setting where the patient may not be as critical, or the patient has been evaluated by a physician or cardiology, you will also see this drug used for rapid atrial rhythms, AFib, AFlutter, ATAC, and you'll also see this used prophylactically at home by patients for other tachydysrhythmias, specifically AFib. But in the ACLS world, we say we mainly are using this for ventricular fibrillation or ventricular tachycardia, whether with or without a pulse. So remember that this drug lasts a long time. It has a bolus half-life of greater than 30 minutes, and dosing on this works like this. The initial dose in cardiac arrest is 300 milligrams IV push. After our 4-minute cycles of CPR, so that would be two 2-minute cycles with a medication in between, we would add our repeat dose of amiodarone, which is 150 milligrams per minute, and that's the bolus dose max for your cardiac arrest patient during that cardiac event. If you happen to be using this for a patient who does have a pulse but has ventricular tachycardia and is relatively stable, we would give 150 milligrams, which is half of the cardiac arrest initial dose, but we have to remember that we have to give it slowly. Again, I said that this drug causes hypotension, so that we have to give the drug over about 10 minutes. And usually what happens is we mix it into a small bag and run that bag in over 10 minutes, whether you use a 50 ml bag, a 100 ml bag, or even a syringe pump, whatever your policy is. Once the patient has a change in rhythm out of ventricular fibrillation or out of that ventricular tachycardia, frequently at the physician's discretion, a maintenance infusion at 1 milligram a minute is utilized at that point. So the goal is to keep the level up until we figure out why the patient had the ventricular dysrhythmia. Most patients didn't go into ventricular fibrillation because they were low on amiodarone. So what might happen is we might start this amiodarone infusion at 1 milligram per minute, and then later on when we learn that the patient's potassium was high and we fix that, they may stop the amiodarone. Again, physician's discretion of when and how much to give. So cautions with this drug are that we shouldn't use it in patients who are bradycardic or patients who are already hypotensive, because it can cause both of those things. So when we look at other antidysrhythmics, lidocaine has been an antidysrhythmic that we've used since the 70s. In 2000, we started using amiodarone in the guidelines, and lidocaine kind of fell out of favor for a while. As of 2018, the recommendation now is, at the physician's discretion, we can administer lidocaine instead of amiodarone for ventricular fibrillation, ventricular tachycardia, ventricular ectopics, at a dose of 1 to 1.5 milligrams per kilogram, and that can be repeated at up to 3 milligrams per kilogram of a total dose. Other drugs that we may see used, even though they may not be on your specific course exam, I think we're remiss if we don't discuss those. Procainamide is a long-term antidysrhythmic. It's been around for a long time. It works excellent in VTAC. It's given as an infusion initially at generally 20 to 50 milligrams a minute, and that can be used as well, or maybe ordered by physicians, especially in the cardiac settings. Several years ago, beta-pace or sotalol was approved for ventricular tachycardia in the United States. While we had been using it for oral doses prior to that, it had not been approved for IV use. So let's talk next about slowing down tachydysrhythmias. So that would be heart rates over 150 with no discernible P wave. And the first one we'll talk about is atrial tachycardia, or generically some people call this SVT. So when we use adenosine for this, adenosine slows conduction and stops reentry. Basically what that means is it causes the myocardial cells to quickly depolarize, and the patient has what the company calls a sinus pause, what you or I may look at the heart monitor and call asystole, for a brief period, and then hopefully the sinus node takes over and the heart starts beating regularly at a normal rate. The dosing on this is 6 milligrams. If you remember, this is a drug that you have to push as rapidly as you can, and then put a flush in behind it to get the drug to make it to the heart quickly, as the half-life is very short on this drug. If the initial dose of 6 milligrams doesn't work, you can administer 12 milligrams or double that dose after that, one time, with even in a short period, because the half-life is so short. Remember that when you give this drug to the patient and he has that that change from a heart rate of 200 to a heart rate of 0 for a brief period, they're going to feel unique. They're going to have chest pain, shortness of breath, palpitations. Their EKG is going to look unique. It might look like asystole. It might look like a heart block. It might look like ventricular beats. Just realize that that's going to happen on those patients. If the patient is being given this medication through a central line, or where the patient is a heart transplant patient, we change the dose by reducing it a little bit. And there's also some other patients who you might change the dose on if they're taking carbamazepine or Tegretol. You may see a physician choose to change dosing on those patients as well. If the patient has one of these two arrhythmias that's at 150 or greater sustained, that would be either atrial fibrillation or atrial flutter. Adenosine just doesn't work. So we need to use a calcium channel blocker as recommended by the guidelines, or even a beta blocker at the physician's discretion. So what we're trying to do really is slow the heart rate down and then allow the cardiology folks to determine what to do with them long term after that. So calcium channel blockers such as diltiazem, cardizem, the book dose is 0.25 milligrams per kilogram, followed by 0.35 milligrams per kilogram. What you'll frequently find is an order for somewhere between 15 and 20 milligrams slowly until the rate gets under control, and the rate slows down under 100. We should be careful if the patient's been given an IV beta blocker with giving them an IV calcium channel blocker at the same time. Certainly patients are on both of those medications. We're just saying be cautious doing both of those at the same time. In a patient, you may slow them down too much. Patients with a history of Wolff-Parkinson-White syndrome, a conduction abnormality system that causes tachydysrhythmias, shouldn't have calcium channel blockers. And obviously patients with lower heart rates or heart blocks wouldn't be indicated for a calcium channel blocker anyway. Whether the physician uses a calcium channel blocker or a beta blocker is up to his or her discretion. So if we look at all the options for tachyarrhythmias, you'll see that this is the reason the recommendation for tachydysrhythmias is generally control the heart rate, keep the patient stable, and allow the cardiac folks to determine what to do with them after that. So we have a number of different options here. A couple last meds I'm going to talk about are what I call the what-if meds. What if the standard medications I'm using are not working to manage this patient's dysrhythmia? So these are things that may fall into the H's and T's, but if we look at things like magnesium sulfate, hypomagnesemia is one of the leading causes of torsades, and some people would say that irretractable VFib, meaning VFib that's not responding to your treatment, could actually be torsades if we haven't diagnosed specifically torsades or torsades de pois as properly pronounced. Magnesium 1 to 2 grams added to your resuscitation sequence if your patient is in cardiac arrest, followed by your defibrillation sequence would be appropriate. If the patient's not in cardiac arrest, magnesium 1 to 2 grams diluted and given over several minutes is utilized. We have to be cautious with magnesium because too much magnesium can cause cardiovascular collapse or cardiac arrest. Actually, when we talk about 1 to 2 grams, if you think about the labor and delivery folks, they're frequently giving 5-10 grams at a time. So 1 gram is probably not going to put somebody in cardiac arrest. Sodium bicarbonate is one of the drugs that we use to reverse acidosis, ideally in the known metabolic acidosis patient. So ideally we get blood gases. Though occasionally we might see this given as a diagnostic tool after a long-term cardiac arrest or a diabetic who's in ketoacidosis or an aspirin overdose. Generally, it's not one of our first-line drugs unless we're using it as an antidote based on poison control or based on the history information that we know. The dose is 1 milliequivalent per kilogram. The thing to remember is it comes in a large ampule of 50 milliliters. Most of the drugs that we give are no more than 10 milliliters. So a 50 milliliter ampule is designed for a 100 or 110 pound patient. So you may be giving more than one of these large ampules. The last drug that we'll talk about in this section is going to be calcium chloride. So calcium chloride, again, is not regularly used anymore. It's indicated with patients who are hyperkalemic, which could be the renal failure patient or the dialysis patient who has not been dialyzed, hypocalcemia, or an overdose of either magnesium sulfate or calcium channel blocker. The dose is between 500 milligrams and 1 gram, which is what the ampule generally carries, and those medications are used Again, a little bit of outside the box thinking for ACLS, not some of the medications that are used in every single cardiac arrest. That concludes the first section of ACLS pharmacology, those drugs that you should be able to open quickly, administer appropriately in a patient suffering a critical cardiac event or cardiac arrest. In pharmacology 2, we use these as the agents to manage myocardial infarction or complications, either pre-cardiac arrest or post-cardiac arrest. So these are stabilization drugs, not always as urgent as the patient who is in cardiac arrest and receiving CPR. Here's what we try to remember. Whether we're talking pre-cardiac arrest complications or post-cardiac arrest complications, we treat the patient in an order of three things. Number one, after we're assured that they're breathing and oxygenated effectively, treat their heart rate. Then stabilize their heart rhythm. And what that generally means is if they were given an antidysrhythmic during their cardiac arrest, they should get an infusion of that antiarrhythmic at 1 milligram per minute, whichever antiarrhythmic the physician chose, whether it was amiodarone, lidocaine, or even procainamide. All of those infusions start at 1 milligram per minute. And the last thing we treat is blood pressure. So we treat heart rate first, heart rhythm second, stabilization, and then blood pressure. So as we talk about that, we've already talked about treating the heart rate and the rhythm in the last section. Let's talk about managing blood pressure post-cardiac arrest. And what we say is this. At the very top of the slide, we say that we should give fluids in the patient who is appropriate to get them. And what that means is if the patient is not in congestive heart failure right now with congestion in their lungs, we can give fluids in whatever increment is appropriate at your setting, up to 1 to 2 liters. Our goal is systolic blood pressure greater than 90. If the fluids are not appropriate for that patient because of congestive heart failure or pulmonary congestion, or if you've tried fluids and the blood pressure will not come up to greater than 90 systolic, we may need to use a vasopressor or an inotrope or a combination. So the common ones that we see used now are norepinephrine, which is sometimes called Levophed, dopamine, not used as much now, or an infusion of epinephrine. So remember what I said earlier. Epinephrine should not be pushed into a patient unless they're in cardiac arrest. If we're going to use epinephrine to bring up blood pressure or even heart rate, it needs to be significantly diluted. And we'll talk about that in a second, whether it's put it in a drip bag or dilute it into a very minute amount into a syringe and slowly push it into the patient. Our goal is bring the blood pressure up. So when we talk about norepinephrine or Levophed, this drug is a potent alpha vasoconstrictor. So it causes vasoconstriction in all vessels. By vasoconstricting the patient, the heart hopefully can squeeze hard enough to bring blood pressure up. And if we look, it's a very small amount. We put one concentration of 4 milligrams into a 250 bag. You might do it a little bit differently at your facility. This is just a simple example. And the infusion is 0.1 to 0.5 micrograms per kilogram per minute, which means your drip is going to come pre-mixed. You're going to set it up to your pump, and you're going to set the pump to run at 30 mils an hour for an 80 kilogram patient. And we'll titrate that to an effective blood pressure. We have to be careful with this drug because it's such a potent vasoconstrictor that if it infiltrates, we get a lot of tissue sloughing and potential for infection and even amputation of an extremity if it's not caught and managed early on. Dopamine, I'm still going to talk about it even though we don't see it used as much for blood pressure. It's still in the ACLS guidelines. We use it for the patients who have cardiogenic shock. We use it for the patients who have significant bradycardia. This drug, along with the alpha stimulation like norepinephrine, also increases the heart rate and heart force a little bit to increase blood pressure. And it's dose dependent. If you look, The mid dose is generally where we start, where you get a little bit of alpha, a little bit of beta, so the heart beats a little bit harder, a little bit faster, but it also doesn't affect the renal and mesentery vessels, meaning that the kidneys are still perfused at these mid doses. The standard starting dose is about 5 mics per kilogram per minute, and then it's increased up to no more than 20 mics per kilogram per minute. Again, not used as much. So in using an epinephrine infusion for management of bradycardia or hypotension, it's very similar to norepinephrine. So epinephrine is going to give us some vasoconstriction as well as some increased heart rate. And the way this is done, remember I said we should avoid pushing standard concentration epinephrine into a patient. So we take 4 milligrams of epinephrine into a 250 ml bag, and then we're going to infuse that. The book dose says 0.1 to 0.5 mics per kilogram per minute. Generally what's going to happen is we're going to be giving at 0.1 mics per kilogram per minute to an 80 kilogram patient. That's going to give you 8 mics per minute, which is going to be 30 mils an hour. So this is a lot of long, complex talking. In reality, you're going to have a pump that does this for you, or a chart that you look this up on, rather than having to try and do this in your head. Another procedure that's being used now is where we make an epinephrine infusion into a syringe, or what we call a push presser. So this needs to be done by clinicians who are very familiar with this, because what we're going to do is we're going to take a regular cardiac epinephrine, a 1 to 10,000 epinephrine, and we're going to open it. And remember that these often open from the bottom, which is kind of a trick because everything else in this country opens from the top. You open the bottom of the box, you take that epinephrine out. You then take 1 milliliter of that epinephrine and put it into another 10 milliliter syringe. You fill the rest of that syringe with saline, and you put your original cardiac epinephrine down. Your syringe that you now have mixed with the diluted epinephrine is a 1 to 100,000 concentration, and we can slowly push that into the patient at 1 milliliter per minute. So what you're effectively doing is you're making a rapid epinephrine infusion in a small syringe until you can get the full infusion completed. So when we look at nitroglycerin, I always say that people drive up and down the street, they take nitroglycerin when they're driving. They walk through the store and they take nitroglycerin when they walk through the store. Their physician has told them, if you have chest pain that lasts more than this many minutes, take a nitroglycerin. And nitroglycerin has the potential to cause some hypotension. What I always remind you is when you give the patient a nitroglycerin, you're responsible for what happens to him. So you should be prepared when you give nitroglycerin to manage hypotension if that occurs. So what I'm really saying is you should be ready to start an IV, or at least have an IV started if you're giving it in most cases. You should know that if the patient becomes weak or dizzy and he's not laying him down may cause him to not have that syncopal episode. And what we're going to say is nitroglycerin can be used initially as a sublingual pill, spray, or even a paste put on the patient's torso somewhere. It's used for any cardiac event initially, angina, myocardial infarction, congestive heart failure, and sometimes congestive heart failure with hypertension. You might see for continuous use IV nitroglycerin for the patient who has continual symptoms that don't subside with the sublingual or the paste. For patients that have congestive heart failure, or for patients who are having a STEMI and have hypertension, we may see that utilized. Remember, this drug causes vasodilation, which may cause a headache, may drop their blood pressure. It also reduces the workload of the heart by changing the venous capacitance, or increasing venous capacitance. That is, blood is less likely to make it back to the heart and more likely to stay in the vascular system. We generally give the sublingual at 3 to 5 minute intervals, provided the blood pressure allows. And we do that up to about 3 times. And again, this will be physician preference. Paste is usually used at about a ½ inch to an inch at a time. And the infusions may be at higher doses of 10 to 20 mics per minute if you're using IV in your EMS system or IV in your emergency department or in your cardiac floor. Obviously, you'll have a standard drip that you use for that. Some cautions that we have to remember about nitroglycerin. Patients with hypotension cannot have nitroglycerin. Outside of patients with congestive heart failure, if the patient is significantly tachycardic, he shouldn't get nitroglycerin, and significantly bradycardic. The more common things that we need to look for are, number one, blood pressure. Number two, the patient who might be taking an erectile dysfunction medication. Now, the problem that we're running into is everybody knows the name Viagra, Cialis, Levitra. However, the patient who now gets the generic sildenafil, tadalafil, or one of the other generics now may not be able to tell you he or she takes that. And I say he or she because we treat patients who may have pulmonary hypertension, and the treatment for that happens to be Viagra. I once had a patient who told me he did not take anything for erectile dysfunction. And when I looked at his meds, he was taking Cialis 5 milligrams every day. And I thought, what is he, a bar hopper at 85 years old? What I really learned was he was taking that for his enlarged prostate. So if you ask him if he takes anything for erectile dysfunction, he or she is going to say no. Remember that it's not just the elderly male who takes it. Females take it for other medical conditions. Females and males take it recreationally as well. So food for thought. If you're going to give somebody nitroglycerin, ask them about these medications before. Because what happens is the medication causes veno and vasodilation, and when a patient is given nitroglycerin, it causes the same. We now have a blood pressure drop, and the patient, if he's really having a cardiac event, is not able to recover because of the medication, phosphodiesterase inhibitor, being given to them and causing them to have continued vasodilation. Those patients don't compensate well, and they may drop their pressure during a cardiac event. The last patient that we shouldn't give nitro to is a patient who has a right-sided myocardial infarction. That is a right ventricular infarction. This requires somebody who understands interpretation of 12-lead ECGs prior to giving the nitroglycerin. So you don't necessarily all have to be able to interpret a right ventricular infarction, but somebody should be evaluating the patient, especially if he has an inferior infarction, prior to giving him nitroglycerin. So if 3 nitroglycerins don't take away the patient's chest pain, the goal is to manage their pain to reduce their anxiety. If they are having a STEMI, meaning the EKG shows that they're having a heart attack, they would then be a candidate for morphine to control their pain. So the latest guidelines still call for morphine. They've reduced the incidence of using morphine to saying only give it to patients who are having a STEMI. If the patient is having a EKG that does not show that he's having a myocardial infarction at that point, the morphine may be withheld. Just as a point of interest, you may see other medications utilized to manage cardiac chest pain other than morphine, just based on some studies that have been coming out over the last several years. The dose on this is small increments, 2 to 4 milligrams, until we reduce the pain. Probably the most important thing you'll do for somebody who's having an acute coronary syndrome, or that is a cardiac event, is to give them aspirin. Aspirin acts as an antiplatelet drug by blocking the effects of a chemical called thromboxane A2. Thromboxane A2 causes vasoconstriction in the coronary vessel when it's damaged. It also causes the platelets to stick together a little bit more aggressively. Aspirin doesn't allow that to happen, so what may happen is some blood may be able to move past the myocardial infarction site and give a little bit of perfusion to the myocardium, and that area does not become infarcted as quickly or as aggressively. The dosing on this, they're not really sure if giving them 2 chewable baby aspirins, 4 chewable baby aspirins, or 1 adult aspirin is appropriate. What they know is chewing the aspirin works well. Using a coated aspirin does not work well. So whatever your policy is where you work, we would say give them somewhere between 2 and 4 baby aspirin or 1 regular aspirin early on. So in looking at the medications we just said for treating the patient who's having a cardiac event, I used an acronym, the Lightbulb Treatment. Turn it on in the AM. That is oxygen if needed, nitroglycerin for pain or congestive heart failure, aspirin early and always unless they're truly allergic to aspirin. Not saying, oh, my doctor said don't take it because I take Coumadin. Truly allergic. Yep, I swell up, I get hives, I have to get an EpiPen. That's allergic. And morphine, as appropriate in STEMI. So O-N-A-M, on in the AM, is the acronym that we try to remember. Other antiplatelet drugs or other drugs to stop the future clotting are things like Clopidogrel, which is Plavix. We'll use Plavix in conjunction with aspirin to stop clotting in a different manner. And the standard dose is a PO dose of somewhere between 75 and 300 milligrams, depending on the patient's medical condition and whether or not they think he's going to be getting a bypass surgery in the next day or so. To open up the vessel, we have medications that are used as fibrinolytics to eat the clot and move the clot away. So this would be in the patient who we could not get to a cath lab, or we didn't have a cath lab, or we're having a cerebral infarction, meaning a clot in the blood vessel in the brain. So what happens is this medication, or these classification of medications, eats the clot that's there, removes the clot from the area, and helps reperfuse that brain or coronary vessel or coronary area following that. We have some time limits on this. What we say is, if we're giving this for a patient in STEMI, which we don't do as much anymore, but you still may, it should be less than 12 hours of their cardiac event onset. If we're using it in stroke, the general rule still is we should be giving a fibrinolytic for strokes 3 hours or less from the onset of symptoms. However, now that we see some specialty hospitals who are able to do interventional techniques, and we see some more specialists in stroke, like strokeologists or specialty neurologists, we see that that time can be extended to 4, 5, or 6 hours depending on the facility. But the general is still 3 hours or less for an embolic stroke, with a footnote that says we could extend it longer for these meds. So just as an understanding, when we talk about STEMI or ST segment elevation, we don't expect everybody to be able to interpret a 12-lead ECG. However, we want you to understand the term and what that means. So if we look at the top EKG, or look at the one on the far right. So if we look at the little EKG complex on the far right, that's showing you a regular rhythm strip complex. So when you have to interpret an EKG, you're worried about, is there a P wave? Is there a P with every QRS? Is there a wide or a narrow QRS complex? What is the weight? What is the rhythm? When we interpret the 12 lead, we put 10 wires on the patient. We take a picture of a couple of seconds from each different area of the heart, from the bottom looking up from both sides, from the top looking down, and then around here, here, and here. And all we're looking for is, what is the ST segment doing after the QRS? So is there elevation of the ST segment after the QRS? That's our goal. So if you look at the top EKG and you look down to the fourth line, that would be lead 2. You can see that lead 2, the T wave at the end, never comes back to baseline. Lead 2 and lead AVF are doing the same thing there. Now, just as a point of interest, if you look at the bottom EKG, what we see there is a wide complex. That's a left bundle branch block. And a left bundle branch block, and that one may even have a little bit of left ventricular hypertrophy from strain, those EKGs can trick you, and they can look like ST segment elevation. That's the reason that the EKG needs to be evaluated by somebody proficient at EKGs before we determine this to be a STEMI. Now, on a side note, sometimes a left bundle branch block that is a new onset with cardiac symptoms may be considered an acute MI or a STEMI in some patients. So when we talk about giving those fibrinolytics to eat up the clot versus sending the patient for PCI or to the cardiac cath center, we know there's a lot of contraindications. So bleeding disorders, internal bleeding, recent surgeries, previous strokes, neoplasms and aneurysms, hypertension, pregnancy, all of those are contraindicated for the drugs TPA for cerebral stroke, or Retavase or tenecteplase for a cardiac occlusion or an MI. Some other anticoagulant drugs that you may see, even though they may not ask you about these on a standard ACLS test, those of you working in facilities that manage cardiac patients, sometimes you'll give patients heparin to stop future clots, or low molecular weight heparin like Lovenox. You may see glycoprotein inhibitors used to manage these patients, especially these patients who didn't have a STEMI and aren't going to the cath lab immediately. What I'd like to say now is take a break, and thanks for staying awake.